Thank you very much. As I was introduced, I'm John Einck. I'm fortunate enough to be a faculty member at UCSD, and I've also been very fortunate to be asked by both Dr. Munt and Brandon Fisher to be part of the Radiating Hope project in Senegal. So that's what I'd like to talk a little bit more about today. So I think those of you, there are several of you in the audience that have been there. Beautiful country. You can see the capital of the country is actually the geographic location is one of the problems with cancer care in the country. Similar to Tanzania, the capital's on the coast, juts out on a peninsula into the Atlantic, and the rest of the country, you've got parts of the country that are 600 kilometers away from the capital. As East Africa has a huge incidence of cervical cancer, so does West Africa. These numbers are from Globocon 2008, but you've seen some of the numbers from Globocon 2012. It's gone up significantly, and I think that's just better diagnosis. 19.4 cases per 100,000 women worldwide. In Senegal, 15.8 worldwide, and in the US as a comparison, you can see it's 8 per 100,000. So in Senegal, in 2008, there were 1,197 cases of cervical cancer and 795 deaths. So it is a major case of cancer mortality in Senegal. Less than 10% of women are screened. It doesn't seem to matter whether they live in rural environments or urban environments for the commonness of screening. And you can see in Senegal, which is different from other parts of West Africa, the fastest growing number of new cases is in women 15 to 44 years of age. So this is a young group of women that are being diagnosed with cervical cancer. This is Institut Curie, which is at the Hôpital Aristide Le Dantec in Senegal. Again, jutting out on a peninsula many miles from the closest, from much of the country. This is the only radiation therapy center in Senegal and is also a referral center for multiple countries. So Mauritania, Guinea-Bissau, Mali, all send their patients here for radiation therapy. The center is equipped with a cobalt-60 unit. There's a fluoroscopic Varian Zimatron fluoroscopic SIM. And prior to 2013 in our involvement, no brachytherapy. Just, this is a little bit complicated. Sol Cobalt is the cobalt room, and you can see there is a number of circuitous hallways to get to Salle de la Simulation, which is the simulator room. So this was a major logistical task to figure out, let's put the HDR machine in the only shielded room, but yet the procedures are going to be done in the simulator, and the patients are going to have to be transported through the clinic. So at the Institut Curie, there are 2 radiation oncologists, 3 physicists, 1 nurse, 2 radiation therapists, and they treat an average of about 40 or 50 patients per day. This is their paradigm for the treatment of cervical cancer before we got there. So patients with early stage disease, which was a minority, I'll show you their breakdown for stage in a second. Patients with early stage disease, stage 1, stage 1B, stage 2A, if they weren't surgical candidates up front, they would get 4,600 centigrade and 23 fractions, and every patient gets concurrent 5-FU cisplatin chemotherapy. They do have, across the street from the cancer center, an inpatient facility, and they admit all patients for 5-FU and cisplatin. But if you get to the more advanced stages, patients with stage 2B disease, 4,600 centigrade in 23 fractions, if they had a good response, they went to radical hysterectomy. And these were all with a 4-field box with minimal blocking. Patients who had a poor response and were 2B basically received palliative treatment. They weren't surgical candidates. Patients with 3B disease, they receive 3,000 centigrade and 10 fractions. They hypofractionate. They do get chemotherapy with this hypofractionated regimen. And then they get a lateral field as a boost, 1,500 centigrade and 3 additional fractions. So 3 weeks of therapy. Patients with good response or a clinical complete response go to surgery. patients with less than a good response are treated palliatively and they go back home and ultimately die of cervical cancer. So this is the stage breakdown. So you can see how common stage 3, stage 4 is 43% of the patients. Stage 2B, 36% of the patients, and very few had stage 1B and 2A disease and were eligible for upfront surgery. So 27.5% of all patients seen at the Institut Curie are treated for carcinoma of the cervix. So this is a huge, very common problem there. Between January of 2008 and December of 2012, they treated 564 patients with chemoradiotherapy. 90% of those were for intact cervix, 10% were post-op, and 203 went on to surgery with curative intent. So if you sort of subtract the 203 from 564 and then take away the 10%, you can see that there are over 200 patients per year, over 200 patients during that 5-year period that would have been candidates, hopefully, for brachytherapy or for some form of curative therapy for cervical cancer. So the challenge is just that 200 patients at Institut Curie received chemoradiotherapy for palliation with no potential for cure. Brachytherapy, I think we're all sold on brachytherapy for cervical cancer. I don't have to explain that today, but it's instrumental in the ability to cure cervical cancer with radiation. Adam Schulman, who is a physicist in New Jersey, and Radiating Hope, long before my involvement, sought out to bring HDR brachytherapy to Institut Curie in Senegal and offer curative, definitive radiation therapy to these patients. So this was our team on our first visit to Senegal. Senegal is a former slave trading post, and there is a huge monument and an island dedicated to the slave trade and to remembering the slave trade. And so we were all taking a tour of that. So steps to implementation of HDR, I think we all knew well, were going to be afterloader acquisition. So fortunately, that was taken care of before my involvement. A donation was made to Radiating Hope of an HDR afterloader. Space and shielding requirements were critical, but fortunately they already had radiation therapy, so they had a shield involved. And then, of course, there's a lot of work that physicists do that's over my head that needed to be done before we could do any sort of acceptance testing. The source was a little bit of a problem. It requires major red tape and government paperwork to get a 10 Curie iridium source into the country, but that was taken care of as well. We sought out to design a workable dose fractionation schedule. We heard this morning that common in the US is a 4-fraction or 5-fraction regimen, but we didn't think that would work given the requirements of time and space in Senegal, so we looked for other options. We needed to design a safe and reproducible treatment planning process for them. HDR planning systems have a learning curve, and we wanted to make this as foolproof and easy to learn as possible. We wanted to educate and train the staff there. Fortunately, the physicians were already trained in LDR brachytherapy, but we had to teach them that going from LDR fractionation to HDR fractionation was actually quite a significant process. And then finally, we wanted to successfully implement all of this and actually begin treating patients. So initially, we reviewed the ABS guidelines published in 2000 and 2012 for HDR brachytherapy. They really recommend 4,500 centigrade of external beam and 25 fractions for these advanced patients, and then an HDR fraction size of 7.5 gray or less. This is kind of a complicated slide, but we reviewed the literature because we really wanted to use a hypofractionated regimen. Were there publications looking at hypofractionated brachytherapy and chemotherapy, which could increase the toxicity? And what was the toxicity of these hypofractionated regimens? So we found a number of them, ranging in fraction size from about 6.5 times 3, which we felt was quite low, and all the way up to 10 gray times 3 when patients had lower whole pelvic doses. And you see there's quite an experience with 9 gray times 2. But these were centers that had done some form of planning for each individual patient, and we were uncomfortable going with that approach. So we really settled upon a fractionation of 7.5 times 3 fractions, so it wouldn't be overly cumbersome for the staff. But yet we felt we were not hypofractionating to such a point that we were going to put patients at risk. We decided on a fractionation schedule of 4,600 centigrade and 23 fractions, which is because the center was already doing that. 4 fields, simple blocking, HDR fractionation 7.5 times 3 to point A, with an extra fraction for really poor responders that would tolerate it. We wanted to limit the rectal dose to 70% of the point A dose and bladder dose to 90% of point A. And really this fractionation led to EQD2. You had that concept introduced to you this morning. EQD2 of tumor of 79 gray, which is a little bit low, but that's why we threw in the 4th fraction in the poor responders. A rectum EQD2 of 71 gray and a bladder of 81, which we felt were tolerable because these were point doses and not 2 cc doses as have been published. We knew that with treatment planning there was going to be a learning curve with any treatment planning system. We were unable to do CT-based or MRI-based 3D planning. There was a CT scanner at the hospital. It was down the street, and it would have involved transporting patients on gurneys for about a block to get a CT. We decided on point A dosimetry since we don't have image guidance or the ability to treat a high-risk CTV, and we chose the old ICRU points for rectum and bladder. We also chose, which I think is the most critical part of this, a fixed geometry applicator system. So we could develop a library of plans that could simply be chosen at the console based on which device you put inside the patient and then treated without any potential for dwell time errors. So we actually had a donation of Nucleotron CT-MRI compatible Tandem and ring applicators. It's a very nice fixed geometry system. That ring is always in the same exact place relative to the Tandem. And we chose not to use the rectal retractor because we didn't have moderate sedation for patient comfort. We went back to our LDR days and chose dwell positions to duplicate the 15-10-10-15-15 configuration as many people used in the LDR era. And we put those dwell times into tandems. We chose actually 3 positions on either side of the ring. All applicators were actually CT'd at UCSD, and then we sent the data digitally to the University of Calgary for the actual planning. And then we brought the the data digitally to Senegal and imported into their treatment planning console. We used traditional 15-10-10-15-15 loading. If it was a 4 centimeter tandem, we took away one of the 10s. If it was a 2 centimeter tandem, which we urged them to typically not use, we took away all of the 10s and just did a 15-15-15 configuration. And we scaled them up to deliver 7.5 gray to point A. For each geometry, there are 3 variables. We have 3 tandem lengths, 3 ring sizes. We have 3 angles. And so that led to 27 different configurations which we created pre-plans for. This is an example of one of the Isodose overlays. So they would place the device in the simulator. They would take AP and lateral radiographs. The device overlays are coded with the angle of the device, the tandem length, and the ring diameter. And we pre-printed Isodose curves of 150%, 100%, 90%, 70% to duplicate the ICRU point A dose, the bladder and rectal points. We traveled to Senegal in December of 2012 and did a week of training and education for staff. We just educated them on definitive radiation therapy for cervical cancer, the importance of brachytherapy in this process, the conversion of LDR doses to HDR. We chose a dose fractionation regimen that the clinic felt would work. We did radiation safety training for the HDR machine. And then the physicist met many hours with the physicist to go over dosimetry and physics procedures. In preparation for our team arriving, the center identified in March of 2013 several potential patients for brachytherapy. Most were stage 3B and not eligible for surgery following chemorads. Surgical kits were prepared, so then we had to prepare the devices for implantation with developing sterilization processes. And we performed the first brachytherapy implant in West Africa. This is actually an image from the first patient's dosimetry. You can see the device. I don't have a pointer here, but you can see the device with a 4-centimeter tandem in place, both AP and lateral radiographs. You can see the ICRU bladder and rectal points fall outside of the 90% and 70% isodose lines, respectively. We did 10 procedures on 6 patients over 5 days. We did not have to repack. We used betadine-soaked gauze for packing. The MDs were already well-versed in placement of the applicators and reviewing them for adequate geometry. Treatment procedures were followed well, and the treatments were delivered accurately. In fact, by the end of the stay, we were able to transfer the responsibility of these treatments over so that the physicians were actually doing the brachytherapy procedures, and that the physicists and nurse were taking care of the dosimetry process. So our successes, we acquired and installed an HDR brachytherapy machine at Institut Curie. We set up a process for GYN HDR brachytherapy that could be followed safely and effectively. We gradually transferred responsibility over the process to local MDs and to the local staff. And I think a real success is that we chose fixed geometry applicators and a library of plans that could be used accurately and safely, and actually fairly quickly once we got to our 3rd or 4th application. Things that I wouldn't call them failures, but they weren't big successes. We were unprepared for all of the different workarounds we would have to create. We didn't get a total buy-in from local MDs and the administration prior to implementing HDR. We believed it was a good idea for them, but one of the physicians there was not necessarily sold on this whole process. We didn't really work out the space constraints. You know, they're treating 40, 50 patients a day, and so these procedures have to be done after hours, and motivating the staff to do that is a difficult process. We didn't work out processes such as patient analgesia and sterilization of equipment. They were kind of afterthoughts. So the Varian recommended, or the nucleotron recommended procedure for these tandem and ring applicators is Sterad or some sort of sterilization solution, or 5 minutes of autoclaving, which we found out later. So they didn't have sterilization solutions or the potential to get sterilization solutions unless they were donated. So we did a workaround of 5 minutes of autoclave. And you can see what happens when the staff doesn't understand why you can't autoclave plastic applicators for 1 hour like they do the rest of the surgical instruments. So we ruined a number of applicators. We melted them basically because of this 5-minute autoclave became an overnight autoclaving like they did with the remainder of the surgical instruments. Patient analgesia was a problem. They don't have monitors for moderate sedation. They didn't have the drugs for moderate sedation. And I can tell you that there's a Tylenol substitute that they use here. It's intravenous, paracetamol. IV paracetamol doesn't work for patient analgesia for brachytherapy. And we didn't clearly address the costs of afterloader maintenance and cost of supplies. So the source exchange is going to be a major issue for Senegal. I don't remember, Larry, do you remember how much is source exchange for $10,000 a quarter? So that's higher than I thought it was going to be. So that's going to be an issue, getting that sort of money together with an HDR treatment that costs $300 per patient. We didn't address new applicators, so we melted a number of the applicators, and we're going to have to find a way of replacing those, or better yet, getting a set of metal applicators for them that don't require dilatation of the cervix and don't require, and we can easily autoclave. And then just medications for the patients before and after the procedure, I think, is always going to be an issue. So, So in summary, I think we did successfully implement a process for HDR in terms of our fixed geometry applicators, a library of plans that can easily be used at any center without a great knowledge of treatment planning. You do have to have some knowledge of geometry, which the physicians there had. We were able to treat 6 patients over 5 days with HDR brachytherapy. And I just want to acknowledge the folks from Radiating Hope for asking me to be involved in this process. And I want to, in advance, thank Delta Airlines for hopefully getting my bag here this evening. So I don't normally give a talk in jeans and sneakers. So thank you.